that introduction there. First of all, I just want to thank everybody for asking us to come and speak today. I really do think this is an honor to be here. Now, as all of you know, the work of first responders is such that it's a dangerous job. First responders are at risk for physical injury and mental health problems as well. And while we may try to protect ourselves as much as possible through physical fitness, through exercise, through health initiatives, critical stress debriefings, resiliency training, and so on and so forth, no matter what we do, there is no way we can 100% prevent ourselves from developing either a physical injury or a mental health injury. If the right situation happens at the right time, or the wrong situation happens at the wrong time, everybody is at risk for developing an operational stress injury. So today in our presentation, we're going to talk about two such possibilities. One being addictions, the other being post-traumatic stress disorder. Now, if you're going to talk about one of these disorders, you absolutely have to talk about the other because there's a high prevalence rate between the two. If you take a look at the research literature and take a look at individuals who are seeking treatment for addictions, you're going to find, depending on the study, as many as 50% of those individuals also meet criteria for PTSD. Likewise, if you take a look at individuals who are seeking treatment for PTSD, again, depending on the study, up to 75% also have a substance use disorder, substance use problem. Now, this seems to hold no matter what population you look at. If you look at young people, if you look at old people, if you look at men, women, civilians, or veterans, this correspondence or this correlation holds. And about 5 years ago, I guess Dr. V and I didn't really believe the research, so we did a little bit of our own. What we did was we did a survey of our own patients who were coming into treatment for addiction only, and we found within our own patients, approximately 80% reported having experienced at least one significant trauma within their lifetime, and of those, 50% met criteria for PTSD. So that's a really strong correlation. Okay, so I'm going to start off by talking about post-traumatic stress disorder, or PTSD. And I'm actually going to start off by talking about trauma. I always like to give the definition of trauma before talking, because, now I can't see my slides, okay. Always like to start off by giving a definition of trauma, because I find in today's world, the word trauma is very much overused. People will use the word trauma to describe things like a relationship breakup, losing a job at work, failing a semester at school. And even though these events are extremely stressful and can have absolutely profound effects on a person's life, they don't constitute trauma. The clinical or the Dsm definition of trauma is either exposure to the actual or threatened death, serious injury, or sexual violence. And that has to be experienced either directly, witnessed directly, it has to happen to somebody very close to you, or usually within the context of some sort of occupational role, have repeated exposure to some of the very adverse effects or the gory details of the trauma. Okay. So some quick examples of traumatic events, and this is taken from the Life Events Checklist, which is a very popular checklist in the literature. Things on the checklist would be examples such as physical or sexual assault, explosions, accidents, being in combat, natural disasters, fire, etc., etc. Now, if you think about it, most people, at least living in North America, most people will experience maybe a handful of such events within their lifetime. But when I look around the room and I look at the first responders in the room, can anybody even begin to estimate how many events they've experienced within their careers. Anyone? Probably not, because it's just part of your everyday functioning. It's part of your jobs. It's part of what you're doing on a daily basis. So most people, first responder or not, are likely to experience some sort of emotional or behavioral or cognitive distress immediately after exposure to traumatic events. Some examples may include having unwanted memories of the event, maybe some restless sleep, some mild anxiety, some agitation. Maybe you find yourself easily distracted and kind of isolating a little bit more. For most people, these types of symptoms are pretty mild. For others, they're a little bit more severe. They may interfere with your life a little bit, and it may even be severe enough that you might meet criteria for an acute stress disorder. Regardless, either way, for most people, within the first couple of weeks, these symptoms, these difficulties start to dissipate. And within a couple of weeks, people just kind of rebound and go back to where they were before. For other people, not so much. Not only do the symptoms persist beyond the 1 month point, they actually start to worsen. For these individuals, they can go on to develop more serious medical and psychiatric problems such as depression, anxiety, substance use disorders, and post-traumatic stress disorder. And I do want to point out, and I think Debbie mentioned this earlier, PTSD, even though we talk a lot about PTSD, PTSD is not the most common outcome of trauma. As you can see from the board, major depression and anxiety disorder, as well as substance use disorders, tend to be a more common outcome. Substance use disorders for men actually are the most common outcome of having experienced a trauma. This is a little bit of an older study that I'm citing here that says it's number 3 for women. So I just want to say to the women out there, be careful. It's number 3 right now, but it's rising quickly, and actually I think some of the studies are showing that for women, it's number 2. So ladies, we're catching up, and not in a good way. Okay. So post-traumatic stress disorder. I'm not going to go into a lot of details about PTSD. I'm assuming that at this point in time, everybody is quite familiar with the signs and symptoms of PTSD, and if you're not, you probably definitely will be by the end of today. But just some of the highlights with PTSD, you're looking at intrusive recollections, so that would be your flashbacks, your nightmares, etc. A lot of avoidance types of behaviors, alterations in mood, and some of your beliefs, your thinking patterns, as well as hyperarousal and reactivity symptoms. So that would be things like that strong startle reaction or hypervigilance, always needing to be aware of what's going on around you. Now, in order to meet criteria for PTSD, these symptoms have to be present for at least 1 month. And another criteria is that it needs to somehow interfere with either your occupational or your social functioning. So when we talk about impairments in functioning, we're talking about all kinds of things. We're talking about things maybe as simple as finding yourself getting into a lot more arguments with the people around you. This may be family, this may be friends, and these arguments may be taking place because you're finding that absolutely everybody is irritating you. Everybody's just bugging you, so you're lining up, lashing out at everyone around you. You might find yourself declining social invitations, so saying no to showing up for a dinner invitation or to go out and play hockey. You might find yourself not going to the gym anymore because, well, you're finding it's just a little too crowded, it's too loud, everybody there's an idiot, I don't want to hang out with them anymore. And, you know, as you go along, you may find yourself doing things, even though you're following through with activities that you're supposed to be doing, you may find yourself a little less connected with those activities. So for example, you may continue to do things like go and coach or watch your kids' soccer games, and maybe you're cheering them on the sidelines. But even though you're there, you don't really feel like you're there. You feel like you're just kind of going through the motions, that you're just not into it anymore. Now when you look at the impairments in functioning, you'll see that I did not list any occupational impairments. And I actually did that quite purposely. did that purposely because for first responders, as well as for healthcare professionals, the occupational impairments are actually the last things to go. For most people, they hold on to their occupational functioning for as long as possible. There are a couple of theories around how this happens. One being that first responders are their self-esteem and their self-identity is so tied in to what they do for a living, that it becomes who they are. And that felt need to serve is so strong that they'll do everything else except let go of their work functioning. So relationships may fall apart first, parenting may decline, your roles as partner, parent, child, those roles will go to the wayside way before the occupational roles start to suffer. Okay, so how do people typically cope with post-traumatic stress disorder? Well, they do all kinds of things to cope. Sometimes people eat, use food, use sex, exercise. Some of these things may be healthy, such as meditation. Other things, not so much. It doesn't really matter what the person uses. The goal of the coping mechanisms is to do whatever you possibly can to either feel better or, even better so, not feel at all. For some people, the answer, the thing that allows them to keep functioning, to keep working, to keep doing what they need to do, is to use drugs and alcohol. So drugs and alcohol. Why not use drugs and alcohol? After all, drugs and alcohol has been used historically to cure or manage a lot of different disorders. Okay? Anybody in this room ever have a bad cough? Anyone? Persistent cough, maybe, you had pneumonia and you just couldn't get rid of the cough. Did everything you could, you drank tea, you drank honey, nothing worked. Okay, yeah, okay. Ever try this? This is an ad from, I think it was 1901. Heroin. Heroin was once marketed as a cure for coughs. Okay? And every time I put this sign up, for some reason the whole room starts coughing. Okay, so not only was this apparently a cure for coughs, but apparently it was a very economical choice. Less than $5 an ounce. Huh. Anybody can see who this was made by? Bayer, yeah, the people who made aspirin, which makes me a little afraid of what's in aspirin. Okay, here's another one. Anybody here ever struggle with fatigue, exhaustion? Maybe you just come off a long stretch of nights and you just can't get your mojo, you just can't get yourself moving. Okay, yeah, everybody, and it doesn't even have to be a long stretch of nights. Okay, here's the cure. Coca-Cola. Coca-Cola gives you energy, so cure to fatigue. Anybody know why? Cocaine, exactly. Exactly, back then, the original Coke, or actually I should say the original Coke, if anybody remembers New Coke. This was the original Coke. And yeah, it was called Coke for a reason. Had cocaine in it. Okay, one more. Anybody been to the dentist lately? Yeah. Anybody like going to the dentist? Yeah, I didn't think so. Toothaches. Okay. Don't you hate it when you have to go to the dentist because you have a toothache and, I don't know, the dentist is always a pain in the you-know-what to me. Well, instead of going to the dentist, you can try this. Cocaine tooth drops. Yeah. Cocaine, the wonder medicine. It instantaneously cures toothaches. It's less expensive than going to the dentist, and apparently it's a lot more fun than going to the dentist. Okay. So, just as drugs and alcohol have been used to cure all kinds of ailments, people have historically turned to drugs and alcohol to help them out with mental health disorders, including post-traumatic stress disorder. And when you ask somebody with PTSD why they're using drugs, why they're using alcohol, they give you some really, really good reasons as to why they're using it. They'll tell you that, alcohol helps them sleep at night. They use drugs to help them feel less irritable. They feel less irritable, their partners aren't as angry with them, and the dog stops running away from home every time they come in the door. They'll use drugs to numb themselves from the negative effects of flashbacks or other bad memories, and it does help people function a little bit better. If you can numb yourself from some of the emotional distress, help you feel a little less afraid, a little less anxious, you can do those normal things that normal people do, like go to the grocery store or sit through one of those parent-teacher nights at school. And in fact, alcohol actually, in the early stages of PTSD, is actually a very helpful, quotes, medicine. Any substance that allows you to depress your central nervous system will improve symptoms of PTSD in the short run. In the short run, alcohol decreases a person's physiological response to stress by lowering the production of stress hormones, lowering the production of cortisol, and in this way, it helps decrease the emotional distress and the hyperarousal symptoms associated with PTSD. But there is a downside to this, and the downside is that by dampening the emotions, it also prevents a person from being able to process or extinguish the emotional response associated with the PTSD. So what ends up happening is that every time the trauma memory gets activated, the emotional response, be it fear or anxiety or anger or helplessness, whatever, it stays just as strong as when the emotion first got there. It doesn't dampen, it doesn't weaken. So in the long run, what happens is the person needs to continue to need the substance for a prolonged period of time. And with time and extended use, the person starts to run the risk of developing a substance use disorder, be it an addiction, a substance dependence problem, or a substance abuse problem. So let's talk about those three categories of addiction or substance use.
Good morning, folks. Thank you for inviting us here. I know my colleague already said that, but I really want to reiterate that. I'm proud to be here. They call me Dr. V. Vitalogo is my last name, so call me V. It's easier. It's better on my ears. Also, I'm going to be a little bit sometimes harsh, and that's because I really care about this topic. I am myself a recovered drug addict and alcoholic. Anyone know what this is? If not, I'll tell you. In 1920, the Volstead Act, on January 1st, came into effect, making alcohol illegal, prohibited. This here is a prescription from your doctor for medicinal alcohol. It helps with a lot of things. Helps with the common cold, helps with depression, helps with neurosis. The reason why I put this up is because the year prior to the Volstead Act coming into effect, there were approximately 6,000 prescriptions for alcohol. After it came into effect, there were 6 million. Bad ideas never go away. They just be showing themselves up again and again. Alcohol is the #1 killer. Also, the #1 reasons why people visit the emergency room. A few years ago, it was cocaine was #2. Right now, cannabis is becoming #2. I can't wait till they legalize cannabis. Then they can take it out of the medical profession and we can attack it the same way we did others. Now, addiction we talk about because there has to be a clarification on why PTSD is so important in this. Not everybody that gets PTSD will become a drug addict or an alcoholic. But if they have that genetic predisposition, that is a profound event that can change the direction of their lives, especially if they are at risk for addiction. Now, the DSM-5, which came out, is a disaster as far as addiction goes. It has muddled the discussion. Just want to let you know that earlier this spring, addiction medicine in the United States has been finally recognized by the American Board of Medical Specialties as a subspecialty unto its own. What does that mean? That means it has enough evidence to be its own medical specialty, and other specialties in medicine can get a specialization. It's going to come to Canada soon. But I want to break down what I mean by addiction. Because we look at it this way, abuse. Abuse is a behavior. Anyone here ever get drunk on a weekend? Nobody? Come on. That's abuse. You know, you come home, you puke on the cat, everybody gets upset, and you say, never do that again. And you don't. Most people start off that way, especially teenage kids, university kids, until they learn. Dependence. Dependence is a normal physiological response to an external substance. If I was to put you all on morphine for 2 weeks, you will become dependent on it. I take you off that, you will experience withdrawal. Doesn't mean you're an addict. What is addiction? With the first two, once you control the substance or remove it, they get better. And they can go back to social drinking or social use. Because let's be quite honest about this. Most people, do you know that only 9% of people that use heroin get addicted? Around the same percentage are people with cocaine. Same percentage of people with cigarettes, believe it or not. There are social smokers, or those who become dependent can quit quite easily. Addiction is something else. Addiction is a genetically mediated change in brain chemistry that changes the person in their sober state. They are no longer the same. You take away the drug, they actually get worse for a while. Unless somewhere along the line they receive some type of treatment. It is a progressive disease. It is far more genetic than high blood pressure, diabetes, and even breast cancer. And that has been shown. First, addiction is not a symptom. That's a big problem. It isn't a diseasette. It's not a behavior. It's not a form of self-medication. The self-medication hypothesis was proved wrong in 1988 because nobody matches their drug to their psychiatric symptom. Number one drug used by people with depression, anxiety, schizophrenia, bipolar is alcohol. Number two drug now that people use, cannabis. In 1930, if you were a cannabis user, you were usually a jazz musician in Harlem. By 1974, you were some white pasty kid with freckles on a surfboard in California. It is the availability that determines what drug is used. Again, I reiterate, and Nestler, Dr. Eric Nestler, was the one who actually stated this fact, and it is well known in the addiction medicine field. Basically what happens, I think this is a very nice slide. It's taken from long ago, and it shows that addiction, as well as traumatic events, especially when they're together, cause a change in the genetic structure of the brain. These are epigenetic changes and genetic changes. They cause modifications of the genes to establish a circuitry that is active with its main goal to get to that person to use again. It forms very stable memory patterns. And so relapses, as we call them in addiction, are really reactivations of stable memory patterns that make sense to the individual to return to use, thinking that it's going to be okay this time, and forgetting the devastation it's caused previously in their lives. The next slide is one of Nestler's examples of this. Now, he was the one that discovered the delta phosphate protein. Now, what is that protein? That's one of the proteins that causes stable memory patterns. It is activated in addicts and alcoholics. And what it does, as you can see, and too bad I don't have a little pointy thing, but you see that squiggly thing on top? What it does is causes changes, and you see the first blue arrow going down, that causes gene modification. And this gene modification are stable memory and emotion patterns that then affect the frontal part of the brain to make the person not see what the drugs are doing to them, but live with the illusion that the drug is going to do something for them. Now, what is a stable memory pattern? It is the hallmark of addiction. The hallmark of addiction is craving. What is craving? Now, most people think craving is a barfly shaking, begging the bartender for another drink because he has the shakes. That's not the case. That's just an alcoholic not being stupid because they know that they will get into a seizure. What a craving is a narrative, a very stable narrative, stories, there's multiple, that will make complete sense to that individual to return to use despite the devastations it's caused previously. Now in the next few years, and first of all, I just want to say I don't think any drugs are evil. People will drink and they'd be okay. They can smoke pot and they'll be okay. But there is that segment of the population that we deal with that it is devastating. Pass it on to my colleague.
So just as Dr. V said that the hallmark of addiction is the craving narrative, for PTSD, the phenomena of re-experience, the trauma is the hallmark. Now when you get addiction and PTSD coexisting together, what eventually happens is that the addiction hijacks the trauma history. What happens is that the addiction hijacks the flashbacks, the intrusive memories, the trauma-based beliefs, the hyperarousal. And what it does is it uses these memories and these symptoms as material for the craving narrative. The trauma history thus becomes part of the addiction craving narrative, the story that the person tells him or herself that makes it absolutely, positively make sense to pick up yet another drink or use yet another drug, despite all the negative consequences and all the devastation it may cause. And with time, the PTSD and the addiction become so intertwined that any attempt to address one without addressing the other merely serves to worsen or accentuate the first disorder. So for this reason, anyone who's struggling with both addiction and PTSD, it's essential that you address both disorders. And not only that you address both disorders, but that you take a look at the relationship, because it really is a codependent relationship between the two disorders. Now, in our last couple of minutes, I just want to talk a little bit or say a few things about what our experience has been like in terms of us treating first responders in the addiction medicine service at the Homewood. As you guys probably know, we're a civilian facility, but we do have a lot of first responders that come into our facility for treatment. And as wonderful as this is, I do recognize that coming into a facility like ours, there can be some barriers to treatment. One of the first things, and I always think it's so brave that people actually walk through the door and stay through our doors, because one of the first things that hits a lot of people who come into our treatment program is they walk in, they look around and they think, oh my goodness, what am I doing here? I don't come to a place like this. This is a place where I usually bring people. So it can be very difficult to walk through those doors and stay in those doors. Some other barriers that once people get into treatment, that whole thing about still feeling weak or getting in touch with emotions or showing emotions, that can be a real barrier to treatment for both PTSD and for addictions. I think Debbie talked about this just before us, that whole persona of being a rescuer, that persona of needing to be a helper, that's something that we often find extends into treatment. Sitting in groups, living in community with civilians, oftentimes there's that urge to kind of protect people that look a little bit more vulnerable than you are, or to give time or give extra attention at your own expense to people who look like they're worse off than you are. Another barrier that first responders often have in treatment, and this may not even be in a treatment program, this can be in outpatient treatment, group treatment, as well as individual treatment, is that fear of, if I say what's going on in my head, if I talk about some of the things that have been bothering me, that I'm going to overwhelm either the other group members or even my therapist. And that somehow if I let this stuff out, it's going to contaminate the people around me. So those are some of the barriers that first responders often face. A couple of months ago, I was working with a first responder, actually a soldier, who was still an active CF member. And this individual was in a group that I do with uniformed professionals. And during the course of the group, he said to me, this whole thing about PTSD, if I had been conscripted, if we had had the draft, and that's how I landed up in Afghanistan, I could accept that I experienced trauma. I could accept that I had PTSD. But it wasn't that way. I volunteered. I signed up. It was something I very much wanted to do. I was actually excited. Still am excited when I think about going to Afghanistan. Because it was something I chose, I can't think of myself as being the victim of a trauma. I can't think of myself as somebody who has an injury, who has PTSD. And when I think about that interaction with that soldier, the takeaway I have is that, you know, as much education as we've put into in teaching people about operational stress injuries, there's still, at many levels, a lot of resistance. And because of that, I think it's going to be the responsibility of all of us, mental health professionals, first responders, or the people who love first responders. It's going to be the responsibility of all of us to keep talking about these disorders as operational stress injuries, to emphasize that the work we do, we have a lot of work to do in this respect, and that we have to remind people that addiction is a brain disease and that PTSD is an operational stress injury that involves a brain injury. Anything you want to add, Dr. V?
Thank you very much.
So thank you very much for listening to us today, and hope you have a good rest of the conference.
Okay, that was an excellent presentation. And once again, Dr. V and Wendy will be around, and other members of Homewood. So if you need to ask further questions, they'll be more than willing to answer those. I'm just going to set up the next set of slides here, and I'm going to ask Ed Mandler, the Vice President of the Mental Health Commission of Canada, to join me up here on the stage.
Great, thank you very much. Thanks for having me here today. There's a bit of anxiety right off the top because I'm pretty sure at some point I'm going to take a step off of here and fall off the stage. So if that happens, I know that you guys can handle an emergency. Someone will rush up and help me. I hope, right? Someone's willing. But if I told you that I was having a panic attack, or if I told you that I just felt so worthless and empty inside that I couldn't go on with the presentation, would everyone here know what to do? Would everyone know how to help me? Probably in this room, many of you would. Maybe not everyone, but in most meeting rooms, in most places that I would make a presentation like this, there would be no one who would know how to help me if I was having a mental health problem. If I was having a panic attack or was very depressed. But the other thing that gives me anxiety is maybe the slides won't work. And what's more, in most meeting rooms, in most conferences, I probably wouldn't even tell anyone if I was having a panic attack or if I was very depressed. I'd keep it to myself because I'd worry what those people might think of me, right? It's about the stigma. Those look like my slides. So where was I? Stigma, what is stigma? Stigma is, and I know we've heard a little bit about stigma already today earlier, but stigma really is those sets of feelings, beliefs, and attitudes about people with mental illness, or people having mental health problems, that cause us to treat those people differently, treat them as less than equal in many ways. In any other circumstance, we would call that discrimination. So who here in this room, show of hands, who here discriminates against people with mental illness? No one. Or maybe you do, but you don't intend to or don't recognize that you do. I have a friend, Sheila, who's a broadcaster, and she has a national radio show that's on weekly for most of the year, and Sheila uses that venue to talk a little bit about her own experience, and she contrasts being injured. She fell skiing, broke her wrist, and needed surgery, and she had to be off work for a couple of weeks. And you know, while she was off, she got a lot of calls, people calling to say, are you doing all right? She got flowers, she got some cards. When she came back to work, people signed her cast, and they even had a little party for her with a cake that said, welcome back, Sheila. And she felt very included and very cared for. And she contrasts that with being off work for a couple of weeks, or 3 weeks actually, when she was suffering from a major depression. No cards, no flowers, no calls, and when she got back to work, no cake and no party. In fact, people avoided her and tried to stay away from her. I'm sure that none of her colleagues intended to discriminate, but Sheila felt discrimination. And I think that all of us sometimes do that, even if it's unintentional. I want to try to show you a little video, and it may or may not work, but I'll warn you that it starts with a car accident. So if you don't want to see a car accident, close your eyes for a couple minutes. Okay, keep your eyes open. We're not going to see a video. The problem with stigma is that it creates a barrier. And you've already heard about that barrier this morning from some very eloquent speakers talking about their own experiences. I don't want to be seen by my colleagues as having a problem. I don't want to be seen as weak. It creates a barrier to seeking help. And we know that seeking help early is part of the key toward recovery. So what does that mean for first responders, for police and other first responders? Well, we know that PTSD, and we're hearing about PTSD, is one of the possible results of not seeking help early. But there are others, and we heard from a previous speaker, depression, substance abuse, anxiety actually happening much more frequently than PTSD, and are perhaps even precursors to PTSD, where that early intervention may have been helpful. If we look at some stats, you'll see that PTSD in the general population is about 7% of the population experiences PTSD. Now we would ask, why would people in the general population have PTSD? Well, they may be the victim of crimes, they may be the victim of domestic abuse or violence, or the victim of traumatic accidents and so on. Police and military not really much higher than the general population, especially if you compare to the paramedic or correction officer world, where PTSD is seen at about 20% of the population. So why would that be? The police and military are in this study experiencing PTSD at about the same rate as the general population. Well, a couple things. In the military, there is a long-standing mandatory set of training on mental health resilience that's provided in boot camp. It's provided before deployment, after deployment, and when rank changes. So there's some work already happening within the military to help prepare soldiers better for the kind of trauma that they may be experiencing and know how to remain resilient. And we've actually taken that training, and I'll talk about how we work with it a little bit more. In terms of police, I bet that's underreported. Would you agree? The prevalence is probably much higher, but underreported here. So mental health, how do we think of mental illness and mental health? Well, typically we tend to think of it as pretty black and white, or in this case, as pretty green and red. Either you're doing really, really well, you're fine, you're mentally healthy, or you've got an illness. You've got mental illness, there's something wrong with you, you have a disease, and your functioning will probably be impacted forever. That's how we tend to think of mental health and mental illness, when in reality, there's a lot more that happens in between being perfectly normal, being perfectly healthy, and having a diagnosable illness. There's a lot that goes on in between there. We react to the environment around us, and it's perfectly normal to do that. So today, I might be a little bit stressed because I have a presentation to give. And so maybe that makes me a little bit nervous. Maybe I didn't sleep as well as I usually would last night, just thinking about having to do this. And I really am getting close to the edge there, so I'll back up. But that's fine, because once this is over, I have natural mechanisms. I don't even have to think about it. I just subconsciously do the things that take me back to being healthy again. So it's perfectly normal to respond to what's happening around me, and I have the mechanisms, without even thinking about it, to be healthy again. But what happens if I have to give another presentation tomorrow? And then again, one the next day? So now it's been 3 nights I haven't slept very well. I'm feeling more and more anxious, and now, without sleep, I haven't been doing such a great job at work, and my boss is starting to harass me. It's starting to build up, and maybe I'm starting to get more into the injured part of the continuum. As this keeps going, maybe my natural body mechanisms aren't returning me to normal as quickly and as easily as I should. Well, there are some simple techniques, the same kind of things that Olympic athletes do in order to keep their stress level down and maximize their performance. I can use those same kind of techniques if I recognize I'm having problems to help me get back to a healthy state. And that's what the training is all about. It's all about recovery. We often think of recovery in terms of addictions, but recovery from mental illness is not only possible, it's expected. Now, I've been in the healthcare system for a long time, for about 25 years. I worked a little bit as a clinician, but mostly as a healthcare administrator and executive. And throughout that time, I've only had one opportunity to use the healthcare system and the first responder system as the customer. And it happened a decade ago, actually. July 1st, 2006, I was competing in an amateur rodeo. Do I look like I should be competing in an amateur rodeo? Yeah, I shouldn't, but I did. And I attempted to wrestle a steer. If you're familiar with rodeo, well, the steer won. And I got kicked square in the forehead, hard enough to lose consciousness for about a minute or so. So they insisted that I go and see the first aid station, the paramedics who were on site, which I did, and they looked me over and they said, "You seem okay, but if you start to feel funny or ill, come back and see us." Well, sure enough, a couple hours later, I felt really ill. I had a headache, I was nauseous, my face hurt, my neck hurt, my shoulders hurt. I was sweaty and agitated, and just felt the worst I'd ever felt in my life. So I went back and I said, you know, head injury, help me. And they started to do their job. They asked me some questions. They checked my vital signs. They started hooking me up to all kinds of things in the ambulance, and there was a lot of head scratching and murmuring and muttering between the two paramedics. And then suddenly, everything got very animated, and they started chattering in quite an animated way and seemed actually quite happy and confident. And one of them said, "Don't worry, Mr. Mandler, you don't have a head injury, you're having a heart attack, and you're gonna be fine." So why did they suddenly start to get very animated and happy? Well, a couple reasons, I think. First of all, one, they knew what was wrong with me. They knew that it was something real that was wrong with me, and they knew what to do about it, right? So they weren't telling me, oh, just suck it up or walk it off. They weren't thinking that it's a character flaw or I have to try a little harder to make my heart work better. They knew there was something wrong, and they knew exactly what to do about it. And most importantly, they knew if they did their job, I would get better, that it was worth their time to spend doing that job because I would get better, I would recover. And I have recovered. Here I am 10 years later, I have a pretty normal life. I'm not cured, I'm recovered. So I will always have to take medication, I'll always have to, you know, exercise, I'll always have to lie to the cardiologist about what I eat. But I have a normal life, I'm recovered. Now when I contrast that to being a hospital administrator and walking through my emergency department every day, I'd see paramedics, I'd see police bringing in their mental health clients. None of them looked very happy and animated. None of them looked confident that they were going to make things better, and they didn't look like they felt this was a useful use of their time. The lack of realization that recovery is expected, the lack of hope in recovery is a lot of what drives the stigma that stops us from seeking help and that stops us from helping others. The role that the Mental Health Commission plays in recovery is by offering a range of training and activities. Now, I talked about the mental health continuum and those simple skills that people can use to be more resilient. That's included in a training package called the Road to Mental Readiness, which is built on the foundation that the Department of National Defense has used to train officers for about the last almost 10 years. So it's a program designed to reduce stigma as well as build resilience by giving the knowledge to be able to recognize in myself when things aren't going as well as they could be, and having the knowledge to know what are those techniques to help get me back to normal. For supervisors, it actually is a longer course. It's 4 hours for officers, or 8 hours for supervisors, because in addition to supervisors being able to monitor and be resilient in their own mental health, they have a responsibility to watch out for those reporting to them, to see where there are issues and know what to do about that. There's actually also a component of the program that's 4 hours for civilian employees that's called the Working Mind. So that Road to Mental Readiness training is about me. It's about knowing my own reaction to the environment around me and what to do about it. You heard earlier from Deb that she's an instructor in mental health first aid. It's an excellent program. It's a training program as well that trains you to look out for those around you, your colleagues, your family, your friends, your neighbors. It's a 12-hour course. It's like physical first aid. It doesn't, physical first aid teaches you how to recognize a broken arm and stabilize it. It doesn't make you an orthopedic surgeon. Mental health first aid doesn't make you a psychologist or a psychiatrist, but teaches you to recognize when someone is having a mental health problem or difficulty and knowing how to stabilize that situation until the right help can be engaged. Those fall within a national standard for psychological health and safety in the workplace. It's a set of tools and guidelines to make the workplace culturally safe, psychologically safe. It's some guidelines around policies, culture, and those kind of things, so that the environment that you work in can be healthier and more psychologically safe. Suicide prevention, as you've already heard, there's a heightened risk of suicidal behaviors and thoughts amongst first responders, in particular amongst middle-aged men. So in most communities across the country, those two groups overlap and form one of the highest risk groups in any community across the country. And we're working with communities on broad community development approaches to suicide prevention. We also have some guidelines and training packages for peer support, and you are well aware of the importance of peer support, and that peer support can be anything from informally talking to a buddy or a friend to a very formal program where the peer workers are highly trained and regularly supervised. And with that, thank you very much for having me here today. I will be around, pleased to answer any questions or have a discussion. Thank you.
Sabrina is here. If you can join me up here, Sabrina. Our next speaker is Sabrina Runkelawam, if I'm pronouncing that properly. And we're going to be listening to some new approaches in different types of therapies, and she's going to be speaking about Apollo applied research and medicinal cannabis.
Yeah. See here at the top where it says switch it?
So my name is Sabrina. I'm doing a talk on medical cannabis and PTS. And I'll give you a little background about myself while they're figuring this out. So I'm not a physician, and I don't consider myself an academic. My background is in nursing, so I've worked in critical care, so ICU and Emerge. I've also worked at sick kids and pediatrics. I've also worked in mental health at CAMH as well, and a number of other positions. And in the last 15 years, I've actually worked in clinical trials, so helping with the operations of clinical trials to get new drugs to market. So, you know, with my background, I do respect that in terms of clinical trials, that before any prescription is given to a patient, that there's some evidence behind it. I can go look at a book and I can see what the dose should be, how often they should get it, what's the contraindications, and how I can teach a patient on taking that medication. So just over a year ago, I was approached by the owner of Apollo Applied Research, and he was having trouble getting physicians to prescribe, which is not surprising because there's not a lot of evidence with medical cannabis. And so, you know, if someone told me over a year ago I'd be talking on medical cannabis today, I wouldn't believe them. So I actually started as a consultant to begin with, and it was really to help with this clinic and help, you know, with the peace of mind of the physicians that really did want to help their patients, whether it was chronic pain or whatever they're coming with cancer, with whatever conditions, and really feel like they had some evidence behind what they're prescribing. So when I started, I looked at their EMR and really trying to measure outcomes, patient outcomes, whether it's pain scores or anything else. And back then, in the beginning, most of the doctors were only really comfortable with cancer and chronic pain. So that was really kind of what I built in terms of the outcomes that they would measure. So that's a little bit of background about myself. And actually, when I was first hired at Apollo as well, the owner said, you know, could you also train the staff and the patients on how to pick strains? And I said, well, no, let me help you with research first so that we can start collecting data and looking at what strains work and looking at their pain scores and things like that. And we would build up that data so we can actually have some confidence in how we prescribe. So as we started building more and more physicians, because they liked the model of Apollo in terms of looking at patient outcomes and tracking data, maybe about 7-8 months, we started getting psychiatrists on board. And this was a really new thing. We were getting PTS patients, mostly military, and mostly that they were using recreationally. And it was a lot of wives calling us and saying, you know, I need you to help get my husband needs medical cannabis, but he's getting it on the street, and we need you to help with getting him on medical cannabis. So one of the things we did first off is we didn't have a lot of experience in how to prescribe for PTS. So we started working with a lot of different doctors. And I thought, okay, well, you know, and we had doctors sending their patients to us saying, okay, you guys are the research people, figure out how to prescribe. But we didn't really have a lot of patients at that time. We just had a few. So what we did was we started networking with other physicians and looking at who else is prescribing PTS. And, you know, what are they finding that works? And what we found was just a huge array of how doctors were prescribing. Some were just, I don't know, the patient wants medical cannabis, and I'm just going to give them, and they're going to go online and figure out what to get. So, you know, some were on very high THC, some were on very low THC, some were on sativa strains, indica strains. It was just all over the board. Some were getting 10 grams a day, some were getting 1 gram a day. So really, when I looked at all the physicians, it was all over the board. So what we did was we started looking at capturing the data and looking at what seems to work for the PTSD patients. So what I'm going to talk about today is a little bit about our research. Also, I'm going to talk a little bit about regulations, so the legalities. I'm going to talk about recreational versus medical cannabis, because there's a big difference. And when I started over a year ago, I just kind of thought, you know, everyone that gets cannabis is going to be high. So I've learned a lot too in terms of medical cannabis and how that differs from the recreational use. I'm also going to talk a little bit about why the stigma in terms of the history. Medical cannabis was used pretty widely in the past, and kind of what events have happened to really kind of change that stigma in terms of medical cannabis. I mean, we were dealing with patients with PTS that were even scared to come to our clinic. And so how we had to manage patients was so different. We had to do video conferencing. We had patients that were living off the grid. And you know, the only way we could see them, and we actually had to work with their wives. I had one patient that was off the grid. The wife called, and they don't even have a computer. We had to make arrangements for them to go to a friend's house that had a computer, just so that we could do video conferencing. So that patient, it took about 3 months till I got there, and I'll tell you, I was really excited. You know, I talked about working in clinical trials for the last 15 years. This is probably the first study that I'm probably so personally and emotionally connected with patients, because I can tell you, I know all of those patients' stories, all 45 of them that we have in our study. So, you know, I kind of feel like I'm part of the journey as well with them. I'm also going to talk about medical cannabis and PTS, and this is actually the first time that we're actually presenting some of our preliminary results of our PTS study. So we have about 45 patients enrolled, so I'll tell you a little bit about kind of the demographics and some of the outcomes that we've seen. So I talked a little bit about Apollo. It started in 2014, and one of the things that we try to differentiate ourselves is with collecting patient outcome data. We've seen approximately about 10,000 patients across Canada. I'd love to tell you that a lot of those are mental health conditions, but not really. A very small amount, and that's why we're doing this study. And really, we've only started seeing patients with mental health for the last maybe 8 months, because it's only now that we're finding physicians are more comfortable. So we see a lot of conditions, including PTS, depression, sleep disorder, and anxiety. So we do prescribe for those patients. And one of the differences in the last 8 months is that we have brought on psychiatrists, and that's why we're seeing that we're prescribing for mental health conditions as well. We have one doctor, her name is Dr. Joan Quinn, and we like to call her the medicine woman. Her background is she worked years in the military, and that's why she's so open to medical cannabis, because she did see the benefit with a lot of her, with a lot of the military personnel and veterans. So a little bit about our study. So it's a prospective observational trial, and like I said, because the doctors were all over the board in terms of how they prescribe, this was helpful to look at an observational study. So the study doesn't dictate how the patient should be prescribed, but it does track patient outcomes. And it looks at medical cannabis in the treatment of PTSD and associated symptoms. So we are looking at enrolling about 350 patients. We're about 45 now, and that took a lot of effort. Sometimes it takes, like I said, 3 months before a patient sees a physician. And sometimes it takes months before we build even trust, before we even get to the stage where a patient sees one of our physicians. So we looked at PTSD symptoms. We looked at PCL-5. It's a 20-item question where the patient self-reports. And we did want to build a study so that it was easy for patients to collect the data. One thing we realized, a lot of our patients like to be online. They don't want to come into the clinic quite a bit, as you can imagine, especially a medical cannabis clinic, and especially with some of the physicians that are like first responders and military health. They didn't really want to come into a medical cannabis clinic. So we actually built our data collection so that it could be, they could pull it up on their phone, they can use their computer, or we can call them and do it by phone. We also looked at quality of life. We looked at nightmare frequency questionnaire. We also looked at nightmare effects survey. And we looked at collecting adverse events as well. And we did that at baseline, and we tracked it for 4 months. We also looked at other data, like what other prescription meds and therapies, so are they on yoga as well, what other medications they're on. And we looked at sleep quality. And we also looked at alcohol use as well to see if there's any pattern and changes. So I just want to kind of talk about kind of the patient experience flow. And this is very similar with other clinics as well. So the first thing that happens, and I was talking to a gentleman as well who was very interested in, if a patient comes, what happens? So first off, usually we want a referral. Just like when you go to see any kind of specialist, your doctor sends a referral and then you get an appointment. One of the things that we had to change maybe about a year ago is that a lot of doctors are not comfortable. So if a patient goes and says, I've tried all these things for my chronic pain, can you prescribe medical cannabis? A lot of doctors are not comfortable. We even had doctors that said, if you go on medical cannabis, you will no longer be my patient. And so what we had to do is look at, okay, maybe we have to be more flexible, and patients can contact us directly, but we do need information like their condition. We do need to triage them. There are some things that we may not prescribe for, depending on how young they are, under 24. We look at things like, do they have a history of addiction, and just other things that we might want information on. So once that's all done, and we feel like, yes, they meet all the checkpoints to see our physician, we will book them an appointment. It doesn't mean that they'll get medical cannabis, it just means that they'll be assessed by the physician to see if they feel comfortable prescribing. So what happens during that visit is that they get something called a medical document. That's the term that Health Canada uses, and that's specific, that's like a prescription. And that prescription will include how many grams per day they can use, and usually has a THC cap, okay? After that, we have educators. So one thing that has to happen is that a patient has to be registered with a licensed producer, and that's the only legal way to get medical cannabis. And that's and they would have to be under Health Canada, and they have all these kind of guidelines and things to follow. And then they also get education, especially with our naive patients. Some patients are coming in having no idea of how to use this, so we teach them how to vaporize. We don't teach smoking. We teach them how to vaporize. We teach them, recipes, and not just brownie. There's other recipes that they can use, like making butter, so that they can include that with their cooking or whatever they want to do with their butter. So we give them recipes, and we actually have one of our staff who uses medical cannabis for a medical condition as well, and she used to have a company called Shana by the Dozen, and she actually is an expert in baking and all kinds of things, so she does a lot of the teaching if they're interested in edibles. And then we also now, in the last maybe 8-9 months, there's oils, and that makes it much easier because when patients vaporize, it lasts a very short time, maybe a couple hours, whereas oils can last up to 12 hours. Oils kind of make you feel a little more comfortable. It actually looks like medication. So for a 85-year-old patient who's terrified to vaporize, you know, having oils and being able to just put that in their tea or something makes it a lot easier. So there are other options besides smoking and vaping. The other thing is we help them with strain selection. That's much easier with other conditions that we've seen a lot of, like chronic pain and things like that, but it's a little bit more newer for us with PTS. We talk to them about legalities as well. For example, medical cannabis is okay in Canada, but you can't go to the US and other places with the medical cannabis. And even though we train patients and we get them to sign guidelines that sign off that all these checkpoints we've taught, they sometimes leave the country with medical cannabis and they get in a lot of trouble. And then we teach them about where to purchase and how to select and the delivery of the medication. So once they're prescribed and they do meet our eligibility, we always introduce our research study to the patients. The research study is an ethics-approved study, and we do consent them to the study. Now, even if a patient's not in our study, we still collect patient data. So quality of life questions, sleep quality questions, pain, depending on what the condition is, but it's not as extensive as our research studies. So we also, once the patient does get that medical cannabis, specific strain, dose, etc., we don't actually give patients medical cannabis. Sometimes patients come in and are looking for weed, and we don't have that. It actually gets mailed directly to them, directly from the licensed producer that makes it, and it goes directly to their home. And that's the only way they can get it legally. And in terms of the legal aspect of it, a lot of patients think they just want to see the doctor and just give me a card. And then I can go and I can buy it wherever I want. It doesn't work like that. When you actually purchase it from the licensed producer, that's when you get the card and then you get the bottle, and that's the only way to legally have it. So just to touch on the new regulations, as of August 24th, there's new regulations, access to cannabis for medical purposes regulations. And I touched on some of the things. You need to have medical documents or prescription. Patients have to use a licensed producer. That's the only legal way to do it. So you've been hearing the dispensaries and things closing. It's because it's not a legal way to access medical cannabis. LPs have to go through a lot of things in terms of demonstrating compliance and regulatory, so strict quality control, security measures, record keeping, and things like that. One of the new things introduced as of August 24th, which is causing a lot of trouble, is that they decided to add something that says that patients can grow themselves or they can delegate someone to grow. The problem is they have to have a prescription from a doctor in order to do that. That's new regulations. The problem is physicians want to be able to prescribe how many grams and be able to cap THC. Now, if you can imagine, if you give a patient a prescription and they're growing on their own, who knows where they're getting their seeds from, there's no way of a physician being able to know what they're getting. And so from what I know now, there's no physicians that are prescribing for patients to grow themselves or actually delegate that. So we're getting a lot of patients very angry, and I heard Health Canada's getting a lot of questions from patients very angry as well. In terms of recreational versus medical cannabis, I just thought this would be easy to kind of demonstrate the two. Recreational is not legal. Medical cannabis is. One of the things when patients go recreationally is they don't know how much THC or CBD they're getting. And in fact, a lot of times when we do urine drug screen for patients that are using recreationally, we do see cocaine as positive as well. So sometimes recreationally there's traces of cocaine as well, depending on who's making it and I guess mixing things up a little bit. There's no rules on how it's grown, so pesticide use, mold, and all those kinds of things that might give something weight that are not really good for you. There's no requirements for labeling, so when you purchase, you don't really know what you're getting. And it's not physician prescribed, whereas all of that is applicable for medical cannabis. There's requirements for labeling, just like a prescription med. It has to be physician prescribed. And also, one thing that's a little different with medical cannabis, and a lot of people don't know this, is that medical cannabis can come with pure CBD with very little to no THC. So 0.07% THC, where someone's not going to get a high, but they're going to get some benefits of all the other components of medical cannabis. And a lot of people don't know that. How many people do that? Oh, okay. So just a little bit about medical cannabis. So cannabinoids, a class of compounds that act on the cannabinoid receptors in the human body. Endocannabinoids, these are naturally produced in the body. Synthetic cannabinoids, this is where we have the pharmaceutical. So Nebolone is one example. Just a little basic, these are kind of the two common strains. So sativa, people use that for it causes alertness. There's more of a head high if there's THC. They get more energy, more uplifting, and it's usually used for daytime. And actually we find with ADD, sativa tends to work, even though you think it shouldn't, it actually does help with focus. Indica, if you think of indica, you think of in the couch. So it's relaxation, is more of a body high, sleepy, relaxing, and it's for nighttime. So sometimes when we prescribe for patients with high CBD, very low THC during the day, if they do have problems with sleep, we do give them some THC at nighttime to help them sleep. So there's a lot of things in medical cannabis outside of THC. CBD, terpenes, flavonoids are very common. I'll touch a little bit about those characteristics that helps with mental health. So we all know THC. So there's a lot of different properties with THC. One is a muscle relaxant, and it also does have, it's the primary psychoactive component of medical cannabis. In terms of CBD, outside of being a strong anti-inflammatory, it's actually stronger than some of the products on the market. It's an antipsychotic, and it helps reduce anxiety as well. So a lot of times patients think that we'll prescribe them high THC for anxiety, and we actually prescribe them high CBD and very low THC. THC seems to actually have an effect that it increases anxiety. The flavonoids and terpenes. A lot of people think that the terpenes kind of help balance the whole plant in terms of the medical cannabis properties. And it also has an anti-anxiety effect as well. In terms of the endocannabinoid system, so this system has extensive physiological and pathophysiological activity, and some of the areas in terms of mental health, sleep, stress regulation, and mood. And although we're not tracking this, we've had a lot of feedback from wives that it's helped with their sex life. Now, we're not tracking that in any way, but I just thought I'd throw that out there as well. In terms of medical cannabis, what's very similar with mental illness is what they do have in common is stigma. And I'm going to talk a little bit about why this is. And I can tell you, I kind of had a stigma as well over a year ago when I was asked to help in this area of medical cannabis. Just because being a nurse and working in mental health, I kind of saw it more as an addiction and someone getting high using it. So I kind of had my bias as well coming in. So how long do you think medical cannabis has been around? 100 years? 3,000? Yeah? 500? 1,000? So about 3,000. So I only have a certain amount of time, so I'm not going to go too into detail on this. But it's been used widely for a lot of things. Pain, for when someone does surgery as an anesthetic. It's also been used for anxiety and stress. And so there's been a lot of kind of history in terms of the use of medical cannabis. Queen Victoria even used it in 1890 for menstrual cramps. And in 1988, Judge Francis Young, DEA judge, concluded marijuana in natural form is one of the safest drugs, which when I tell you later, it's kind of contradictory. In 1991, there was this discovery of the endocannabinoid system. So I saw that previous to this presentation, there was the heroin. Well, in late 19th century, medical cannabis was a medication. So Eli Lilly, Park Davis, which is now Pfizer, and Squibb & Sons, which is now Bristol Myers Squibb. They were selling this as a tincture. And it was actually in all the pharmacopoeias in terms of the medical benefits as well. So with centuries of cannabis use, what happened? So cannabis kind of fell out of favor early 20th century, and the reason being is increased use of opiates. Now this weekend I did a whole talk on opiate reduction with medical cannabis, so I'm going to try not to confuse the two talks. But we actually did a recent study where we showed that with the oil specifically, we were finding a 53% reduction in opiate use. So that's one of the talks I did this past weekend. So I'm a little tired. I was in Montreal just a couple days ago. It also, the introduction of the Hypodermic Needle and also the discovery of aspirin, which really, some of the factors that caused medical cannabis to come out of favor. In 1923, it became illegal in Canada, so it was actually the first country. So when I prepared the slide way back, I was actually surprised that Canada was the first country. And it was under the Opium and Drug Act. The Marijuana Tax Act in 1937 made it difficult to obtain marijuana for medical purposes. And it started disappearing from all the pharmacopoeias where it did list it as for medical benefits. One of the biggest impacts on medical cannabis was the Federal Bureau of Narcotics under Harry Anslinger. He demonized cannabis and cultivated the film Reefer Madness. So I won't read this, but basically what he was saying is most of the smokers are African American, Hispanic, jazz musician, entertainers. And basically he said this drug causes insanity, criminality, death, and most violence-causing drug in the history of mankind. So it became a controlled, in 1970 it became a Controlled Substance Act. It was a Schedule I, a drug in the US, which basically means that it has no medicinal properties whatsoever. And it's in the same category as heroin. Does anyone know if anyone owns a patent on medical marijuana? Or
USA only.
yes, which is so ironic. And in that patent, it actually says that it has medical benefits, contradictory to it being a Schedule I. In Canada, we're a little better, it's a Schedule II. What's interesting too is THC is the only part that has the kind of high, the psychoactive effects, but CBD is categorized with THC, even though CBD doesn't have those effects. They're categorized together. So just to kind of talk about medical cannabis and some of our preliminary results. Oh, this is not really coming up well. Can you pull it for me? It's my colleague. I'm not sure what's that coming up.
Yeah, that's it.
Is it coming up there? The percentages aren't coming up. Okay, so you're going to shout out the percentage for me.
Yeah.
So one of the things we did with this study is that we were actually tracking civilian versus veteran versus first responder. It's not coming up. So 38% was civilian, and one of the things I found with civilian is it's basically 50% are usually naive, and 50% are already using it recreationally and finding benefit. Now I'm trying to remember, the biggest pie there, the dark green one, is the veteran population, and the majority of them are coming in already experienced with recreational use. First responders were next, and I'll give you the numbers when she pulls it up. First responders are very different. Most of our first responders are police officers. Thank you. And most of them are coming, okay, so civilians 38%, veterans is 31%, first responders was about 23%, and most of them are police officers in our first responder groups, and the majority are coming in naive with no experience recreationally. And 8 are unknown because they didn't complete it. In terms of ethnicity, 84% are white population, 8% Aboriginal, and 8% other. I'm trying to maneuver 2 things. Okay, this is Alicia showing. For the length of time that they've had PTSD, most of it has been over 10 years or 5 to 10 years. That's the biggest population. There's just a few that have been recently diagnosed. In terms of other illnesses, usually people don't come in with just PTS. 85% also had depression, 69% sleep disorder, 85% anxiety, 62% chronic pain, and neurological disorder, 23%. Sorry, I don't know why it's not coming up. In terms of gender, most are males, 69% male and 31% female. When we look at the actual PTSD symptoms itself, and that's with the 20 questions, we did see a decrease from 50.61 at baseline in terms of the score to 37.43. Now mind you, this is still a small group, so as we add more patients, it might change as well. But I'm not a statistician, but my statistician tells me, and she has a lot of experience at CAMH prior to coming to us, that this is statistically significant. So I was very excited to hear that. I can't explain that, but that's what I've been told. In terms of nightmare effects survey, so basically looking at emotional disturbance and interference caused by nightmares, that went down as well from 27.69 to 21.77. Keep in mind, this is just at month 1, okay? Even though this graph looks like a big difference, this is not statistically significant. Average nightmares per week was 4.07 to 3.35. So it's not really, it's almost the same. And that's it. So if anyone has any questions, I'm around.
Thank you. And Homewood and Apollo have tables here set up for
Mic's not on. Microphone's not on.
got that down. This one on? There we go. Perfect. I think the battery's probably dead in that. Okay, so Holman and Apollo, and there's other tables with people that have great information there. We have one last speaker before lunch, and then we'll have a little bit of house cleaning information just before we do break for lunch. And I would ask, I'm not sure if they're here, I haven't seen, but we have another approach, new approach for post-traumatic stress therapy and it's float therapy, and we have a speaker from the Rock Spa here in Kitchener, Waterloo, and my family had a float, and yesterday after setting up, and it was awesome thing. If you've never had an opportunity to do it, it's first time in about a couple of weeks that I've actually been able to sleep, so I was during the process. Well,
Yep. It's not up.
Good morning, everybody. My name is Chris Ball, and I'm from the Rock Spa here in Kitchener. And I'm the coordinator there. And I want to tell you a little bit about float therapy this morning, just before lunch. Has anybody had a float besides Bill and Lynn in here before? Anybody tried float therapy? There's a really neat history behind it. I'm not sure if our... So float therapy was pioneered by Dr. John Lilly back in the 1950s. He was also known as the father of LSD, but that's a whole other presentation. Apparently he did do the LSD in the pod, but we don't do that. We don't do anything in the pod but float. So he was a neuroscientist though, and he wanted to find a way to access the different levels of healing and abilities in our brains. So in order to do that, he wanted to try and create an environment that was as physically, mentally, and emotionally the least stimulation as possible. So he didn't want his subjects to be able to have any physical sensation, light, noise. He wanted to reduce all that very, very much. So he developed the sensory deprivation tank for that reason. Sensory deprivation tank sounds a little intense. Most of the time we use a different name now. We call it float or rest. And that's restricted environmental stimulation technique. Same idea, a little less intense name. So a lot of the tanks that were in the beginning kind of look like the box style. They're still very popular. There's about 11 inches of water in there. You have a shower, you prepare, you open the tank, you step in and you float. A lot of times now though you'll find float pods as well. And the pod is a little friendlier. People that have a concern about claustrophobia find them a little easier to imagine going inside them because of the lid, but they're both very, very, very good. I know that, I think the float center where Bill and Lynn were, they have the box style, correct? Yeah, and we have the float pod. So really, as long as you can float, it doesn't matter which one, just find one and use it. Some places also have a float room. There's a place in Guelph, Moksha Yoga, they have a float room. Some places, like the pod and the box style, are generally for one person, but the float rooms, sometimes you can have 2 or more people. But I always think of, for me, that would kind of be like having ice cubes in a glass, and I think you'd bounce off each other maybe, so I kind of like the single person idea myself. So when you go for a float, what's involved is basically it's the float container. There's about 11 inches of water and almost 1,000 pounds of Epsom salt. So it's very heavily salinated, and that's why you can't sink. That's why it's effortless, and that helps you float. It's very, very clean. Our system, it's filtered physically. It's cleaned with UV light and ozone, and we also use a bit of hydrogen peroxide. So we don't use any chemicals like bromine, chlorine, anything like that in ours. We were the first folks, one of the first folks in Waterloo area to have a float pod, and we invited the health department to come in because we wanted to do everything right. So we're inspected, and everything is very, very, very clean. So they're very safe, and yeah, there's no harsh chemicals for your skin because some people are very sensitive to that. The first question that I usually get when they see our pod is, does that lid go down? And you can just see them stop at the door and they want to know if the lid goes down. This pod, you control the lid. You also control on the box style too. You can have it open a bit, you can have it closed all the way, you can have it halfway if you like. So you're always in control of the environment. You can have lights and music, you can have dark and quiet, you can have any combination that you want. Some people that have a bit of claustrophobia, we show them that there's quite a large space actually between the surface of the water and the top of the pod. So it's not like a tanning bed. I think that's what a lot of people think, is that they're going to be in this tube, but there's a lot of room in here, and it's really quite comfortable once you get into it. So when you're coming to have a float, you have a shower first. That gets rid of any body oils, hair product, perfumes, and then you would get into the pod and you lay back. And different pods have different ways of measuring the time, but it's always looked after for you. Time can kind of be funny in the pod. We had one lady who came roaring out of the experience about 20 minutes into her hour. And she said, my God, I'm so late, I'm so late. We said, what are you talking about? You've been in there for 20 minutes. She thought she'd been in there for 3 hours and that we'd forgotten her because she relaxed so fast and quickly that she just lost track of all time in there. And then other times people go in and they think it's been 5 minutes by the time the prompt comes for you to get out of the pot. Then when you come out, you have another shower. The magnesium in the Epsom salts is fabulous for your skin and your hair, so it's very nice. And it's really quite relaxing. People experience what we call the float glow after. And one of our first clients that came out, he just kind of stood there in the store and he looked around and I said, are you okay? And he said, my God, even the colors are different. So, and it was just the float. So he had a very, very good experience. So yeah, it really does matter. It really does matter. The temperature of the float water is about skin temperature. So people sometimes are wary because they think you're going to be like in a hot tub for an hour, because that can get a little overwhelming. But the temperature of the water itself is just about skin temperature. And when you're in there and you start to relax, sometimes you kind of lose where you start and the water starts, which is kind of cool. People have described it as floating in space or being back in the womb. So it can be very unique to the person. It can be unique depending on how many times you float. It's not always the same either. So why would you want to float? In this day and age, we are not designed to sustain the level of stimulus that most of us are under for such a long period of time. We like to say that we've got a Stone Age body in the information age. And in 10,000 years ago, if a tiger jumped out from behind a bush, generally you ran, the fight or flight saved your life. You got away from the stimulus, and then your stress came back down, hopefully to zero. Who has zero stress nowadays? Sometimes does it even get to 50%? So we have this long, sustained fight or flight effect that is impacting every system in our body. We start to get symptoms, but sometimes you're just supposed to power through it or pull up your socks and keep going, but our bodies will give us symptoms. They'll give us messages to say, this is not going to continue for much longer. So that's why whatever you can find to create relaxation for yourself, it's always great to have more than one tool in the toolbox. It's really hard to get relaxation as deep any way else but floating. Our nervous system workload is reduced by about 90% when you float. I don't know about you, but I could do with 90% less stimulus a lot of the time. Injuries heal faster. Your blood pressure goes down, your heart rate goes down, but your circulation actually improves when you're floating. Because we don't have gravity pulling down on us too, muscles can relax differently, joints can relax differently, tension can be released, and healing can happen a lot faster. But it's also the mental and even the spiritual effects that some people find with floating that are really wonderful. You are able to access the theta brain state, which is just after you wake up and just before you go to sleep. There's a lot of personal growth, there's a lot of healing, there's a lot of deep meditation that can happen at those levels. And those are the things that give our bodies a break so that we can build some of that relaxation in so we can at least interrupt the fight or flight that most of us are under most of the time. So in this day and age, relaxation isn't really a luxury. It basically can work to save your life. Now I don't know if the little video will show, but this in about 18 seconds sums up what we think float does.
Let's go.
I don't know if you can hear it, but you can imagine. There's the shower. generally don't make that noise, but you get the idea. So thank you very much for having me here, and thank you for all the work you do.
Okay, just have, if I can have Gary come on up here, and we're just going to have a little bit of housekeeping, and then we'll head to the food table.